Welcome back to CLOT Conversations, the podcast where we explore the latest evidence shaping thrombosis and antithrombotic care. I'm David Airdrie, Executive Director of Thrombosis Canada, and I'm joined once again by my co-host, Dr. Jamil Abdurrahman from Toronto General Hospital and Dr. Maha Othman from Queen's University in Kingston. Thank you for being with us. Today, we're discussing a clinically important and highly practical topic, major bleeding with Apixaban versus aspirin in patients with subclinical atrial fibrillation based on a pre-specified subanalysis of the ARTESiA randomized clinical trial recently published in JAMA Cardiology. Jamil, I'll turn it over to you to introduce our guest.
We're very pleased to welcome Dr. Deborah Siegal. Dr. Siegal is a clinician scientist hematologist specializing in thrombosis medicine at the Ottawa Hospital. She is an associate professor of medicine and the School of Epidemiology and Public Health at the University of Ottawa, and the scientist at the Ottawa Hospital Research Institute. Her research focuses on improving the safety of anticoagulant therapy, including management of anticoagulate-related bleeding complications, restarting anticoagulation after bleeding, perioperative management of anticoagulants, and antithrombotic therapies for ischemic stroke in patients with cancer. She also serves on the board of directors for Thrombosis Canada.
So, Deborah, it's so lovely to have you today. And why don't we start with the big picture? So, how big an issue is bleeding on DOACs such as Apixaban and on antiplatelet agents like aspirin, particularly in patients with subclinical atrial fibrillation? And what was the motivation for conducting this sub-analysis of ARTESiA?
Thank you so much for the opportunity to be here to talk to you about this analysis and the importance of understanding bleeding. Bleeding is, even in 2026, bleeding is the main complication of treatment with oral anticoagulants. And so patients who are taking oral anticoagulants like DOACs or direct oral anticoagulants for atrial fibrillation or venous thromboembolism experience rates of major, which we think of as being more serious bleeding, of about 2 to 4% per year. And that's quite variable depending on the patient population and the individual drugs and the indication for treatment. But we still see that bleeding on anticoagulants is the number one adverse drug event that brings patients to hospital, to the emergency department, and actually causes death. So it is an important iatrogenic complication of treatments that patients need to prevent clots. So we conducted this sub-analysis of the ARTESiA trial in order to better understand the major bleeding events that occurred in this study.
So you conducted a pre-specified sub-analysis of data from the ARTESiA RCT. Could you give us a summary of the ARTESiA RCT and what was the goal of this sub-analysis?
So patients with subclinical atrial fibrillation, as you mentioned, so those are patients who have atrial fibrillation that's detected on an implanted device like a pacemaker or an implantable cardioverter defibrillator, for example. Those patients may have short episodes of atrial fibrillation that don't quite meet the definition of atrial fibrillation. We call that subclinical. Those patients have an elevated risk of stroke and systemic embolism, but the role of oral anticoagulant treatment in this population is not clear because the rates of stroke are actually lower than those with established AFib. And also there's an increase in the risk of bleeding, as we had already talked about. So ARTESiA was a trial which randomized patients who had device-detected subclinical atrial fibrillation to either receiving treatment with Apixaban at a standard dose, so 5 milligrams twice daily, versus aspirin. And the ARTESiA trial enrolled 3,961 patients, so it was a large trial, and showed that the risk of stroke and systemic embolism was decreased by about 37% with Apixaban compared to aspirin, but that this effect was accompanied by an increase in the risk of major bleeding. And so it's important for us to understand not just the stroke and systemic embolism side of things, but also the major bleeding side of things, because in clinical practice, we want to make sure that we're treating patients so that the net clinical benefit favors benefit over harm. That was why this sub-analysis was done. We have an understanding of what happens to patients after ischemic stroke and systemic embolism. We know that many patients experience fatal events or long-term functional impairments or disability as a result of stroke. But on the bleeding side, it's not as clear to us what happens, what those bleeding events are, where they arise, and what happens to patients after those bleeds. So we thought that it's really important to understand not just the risk, like not just the absolute risk of having a stroke or a bleeding event, but also an understanding of the type and severity of these events. And that's really what helps physicians and patients make decisions about treatment.
So, regarding major bleeding, how did the characteristics of patients who experienced major bleeding differ from those who didn't?
Yeah, so we know that as in other studies, and this has been pretty well established, we know that patients who have major bleeding tend to be older and have a higher degree of comorbidities compared to other patients. And so we did see that in Apixaban as well. There were 133 patients out of the 3,961 who experienced major bleeding. The average age of those patients was older, their body weight was lower, and their body mass index was lower. They also had some differences probably in the distribution of CHADS-VASc or the stroke risk categories that we talk about. Again, this is an older patient population with a number of cardiovascular comorbidities. And then we also saw that patients who had bleeding had a lower creatinine clearance, which implies that they had worse renal function than the patients who didn't have bleeding. So again, some of the major risk factors that we've seen time and time again in other studies have shown up in our study.
Right.
Okay. So with the bleeding events, how do they compare between Apixaban and aspirin, and at what sites did they occur?
Well, what was interesting is we had an opportunity in the ARTESiA trial to characterize the major bleeding events in a different way, maybe than some other trials, because these events were adjudicated by a committee that was blinded to treatment allocation. And this was an independent committee. And not only did we adjudicate whether a major bleeding event happened, so like yes or no, but we adjudicated what criteria were fulfilled in order for that bleeding event to occur. So with ISTH major bleeding, people are probably familiar, fatal bleeding events, bleeding occurring at critical sites, like in the brain or spinal cord, for example, a drop in hemoglobin of 20 grams per liter or more, or transfusion of 2 or more red blood cells. And so what we wanted to understand was, major bleeding is kind of a broad category with criteria that are kind of heterogeneous in terms of maybe their prognostic importance. So what we wanted to understand was, what do the bleeds look like, as opposed to just kind of calling them major bleeds. A big advantage of our study was to say, well, what is actually happening to patients who is experiencing these bleeds? Right. So what was interesting in our study was that we saw patients who were treated with Apixaban had more bleeds at a non-clinical site, whereas the rates of bleeding at critical sites was similar between the two groups. So there was a similar proportion of people in the Apixaban group, 1.3% versus 1.1%, who experienced critical site bleeds. Whereas a higher proportion of people on Apixaban versus aspirin, so that was 3% versus 1.3%, had non-critical site bleeds. And majority of these bleeding events occurred arising from the gastrointestinal tract. So that was kind of the single most common site of non-critical site bleeding in this study.
Right. So I guess you may have alluded to that. The study has used the ISTH definition of major bleeds, which includes several components. Which criteria most commonly drove the classification of major bleeding in ARTESiA?
Yeah, so that's where things kind of got interesting, I think, for us too. We saw that actually the rates of fatal bleeding and critical site bleeding were low and similar between the two treatment groups. So between patients who received Apixaban and those who received aspirin. Where we saw a difference was in the hemoglobin decrease of 20 grams per liter or more, where we saw that there was a difference. A higher proportion of people who were receiving Apixaban had bleeds associated with a drop in hemoglobin compared to those receiving aspirin. And that was about 3.1% versus 1.2%.
Can you tell us a bit about the severity and clinical course of these bleeding events and how they were managed?
Yeah, so this is another kind of novel feature, I think, of this trial and how these events were adjudicated was that the adjudicators not only determined whether or not a major bleeding event occurred and what criteria were fulfilled for that bleed, but also some measure of the clinical severity of presentation and the clinical course of major bleeding. And these were based on criteria that were developed for other types of studies in the venous thromboembolism space, just to give a sense of what type of events they were. They emergencies? Did patients require some treatment? So you'll see if you are looking in the study, we show the distribution of the severity of the clinical bleeds at presentation. The majority of bleeds were not determined to be clinical emergencies, although patients required some treatment. So that could be like a transfusion, for example. And that was sort of the vast majority. So overall, 75% of events, bleeding events that occurred in this trial were not considered to be clinical emergencies by the adjudicators. But some of those folks did require some treatment, and that could have been a transfusion.
So the multivariate analysis identified several predictors for major bleed, and you may have said add something around this, but which factors are independently associated with the bleeding risk?
Yeah, so we did look at some risk predictors. One of the things that came out to be a really important predictor with a high magnitude risk was the use of NSAIDs or nonsteroidal anti-inflammatory drugs. And the reason I want to highlight nonsteroidal anti-inflammatory drugs use is because this is actually a modifiable risk factor for bleeding. And we know that a lot of patients have risk factors for bleeding, such as anemia, renal failure, age, prior bleeding history. Those are things we can't modify. But the use of NSAIDs is something that we can modify. So in this study, I think that was one of the most important findings, is to say, no, that's been shown before, but it's helpful for it to have borne out in our study to say it reinforces the importance of us when we see patients to make sure that we're questioning the use of these drugs and deprescribing as necessary.
So how do your findings compare to prior studies comparing DOAC to aspirin, including the AVROS trial, which looked at Apixaban to aspirin for AFib in patients unsuitable for BKA, and the NOAA AFNet6 trial, which compared edoxaban to aspirin or placebo for atrial high rate episodes?
Yes, the ARTESiA, it's interesting to consider the different types of data that we have in this space. Averroes, as you mentioned, was a randomized trial, slightly different population because those are patients with kind of established atrial fibrillation who were deemed not to be suitable for vitamin K antagonist or warfarin, and they were randomized to either Apixaban 5 milligrams twice daily, which is a standard dose, or aspirin. It was a really important trial because prior to Averroes, aspirin was being used for patients with atrial fibrillation considered to be at high risk of bleeding and not suitable for a VKA. But the Averroes results showed that Apixaban was essentially twice as good at preventing stroke and systemic embolism with a similar risk of bleeding compared to aspirin. So essentially, after the Averroes trial, really aspirin was no longer recommended to be used for atrial fibrillation, reduction of stroke and systemic embolism. I think what's different with regards to our Averroes and our trial is that our patient population was older than the ARTESiA trial. And so it's a bit difficult to compare across trials in this way. Our trial showed that there was an increase in the risk of bleeding with Apixaban compared to aspirin, whereas Averroes didn't. That could potentially be explained by some of the differences in the population that was under study. We found similar results with NOAA AFNet. The use of a DOAC compared to placebo or aspirin reduced the risk of stroke and systemic embolism, and there was an increase in the risk of bleeding. I should mention that in the ARTESiA study that we did, the risk of stroke and systemic embolism was decreased by 37%, which is important. And actually, there was a 45% reduction in the risk of disabling or fatal stroke. So these were important, clinically significant strokes that were prevented. The increase in the risk of bleeding was a risk of 1.7 in the Apixaban group versus 0.94% in the aspirin group, so a small absolute increase in the risk of major bleeding. So one of the insights that we had from this study is that it does matter what the bleeding events are. And one of the maybe provocative things that we proposed in the discussion of our study was that it seems like the strokes that were prevented in ARTESiA with Apixaban may have been more severe than the bleeds that were caused by Apixaban in this trial, and just highlights the importance of us doing further research to understand now we have the prognosis of these events. So that's kind of our next task, is to understand, well, what happened to patients who had major bleeding? But because we saw that the majority of these bleeds were not clinical emergencies, the majority of bleeds were characterized by a drop in hemoglobin, and that there were similar rates of intracranial and fatal bleeding events between the Apixaban and aspirin arm. But again, we saw an important reduction in disabling stroke, made us wonder whether or not that is in fact the case. And that this is something that we need to be thinking about when we're doing these trials, is not just the absolute risk of an event and not just the hazard ratio that characterizes the association, but actually what are the consequences of these events and how do they compare?
Well, this is a good segue to my next question. Well, considering the overall balance, a reduction in the stroke and systemic embolism on one side and the increased major bleed on the other, what do you see as the key clinical takeaway for physicians managing patients with subclinical AF?
It's a good question because again, when ARTESiA came out, there was this, conflicting results where you had, on one hand, you see a benefit. And this is the case in a lot of our trials. When people take anticoagulants, they reduce the risk of thromboembolism. When you take anticoagulants, it increases the risk of bleeding. So to me, the question here clinically is whether or not we can see a net benefit. I think it will be helpful for us to have data regarding the prognosis of these bleeds to confirm our hypothesis that there is benefit. And perhaps that's not a benefit for all patients, but thinking about patients and their risk profile for both of those might be helpful. So there are characteristics that are being uncovered in terms of the risk of stroke among these patients, and certainly novel ways of understanding stroke risk is ongoing. But the same slide for bleeding, right? So these results may apply differently to patients based on their bleeding risk. If you have a patient who's very elderly with renal function, renal impairment, and prior bleeding and anemia and cancer, those characteristics might sway you in one direction or another. I don't think that these results are ready to be implemented in prime time in clinical practice, but certainly understanding what these events are for patients is helpful. That means that both physicians and patients can be better informed about the potential consequences of decisions. So that's how I would apply these to practice.
Perhaps individualized risk assessment
Yes,
and
exactly.
consultation between the physician and the patient as well.
Yeah. And acknowledging uncertainty. But I still think a better understanding of the consequences of different events helps people understand the decision in a different way. And so it's actually something that in thrombosis medicine, I think we've done very well in understanding the risk of thromboembolism for stroke and systemic embolism and AFib and for venous thromboembolism. But I think we're still uncovering the characteristics, the severity, the prognosis associated with different types of bleeding events. And I think more information about that will help us make better decisions for our patients.
So is there anything that we haven't discussed today that you'd like to bring up?
No, I think I was able to. Thank you. Those are great questions.
Dr. Siegal, thank you for joining us and for helping us better understand not only the frequency of bleeding with Apixaban in subclinical atrial fibrillation, but also the nature and severity of those events and how that should inform clinical decision making. And to our listeners, you'll find a link to the full ARTESiA subanalysis in the show notes. And we always appreciate hearing from our listeners. If you have any comments, questions, or ideas for future episodes, please email us at info@thrombosiscanada.ca. And be sure to follow or subscribe so you never miss an episode. And visit thrombosiscanada.ca for clinical tools, patient resources, and information on our educational programs. Before we close, if you value this podcast and the work of Thrombosis Canada, please consider becoming a thrombosis champion with a monthly gift for as little as $10 a month. Your support helps us continue delivering high-quality, evidence-based education for healthcare professionals and patients across Canada. Thank you, everybody, for listening, and we'll see you next time on CLOT Conversations.